So this is the case number 4 now.
AR1.
This patient presented with the lightheadedness and dyspnea on exertion. Had a bypass surgery.
At the right sinus.
And the various things which are shown here. Patient has a surgical valve replacement with 23 millimeter
Take your
magna
T of
T
T
valve.
Right sinus.
And the medical therapy, you can see good medical therapy. Patient has a low ejection fraction.
AR1 is coming.
And
Get over here, man.
the rest of things are okay, with the creatinine being, the BMI is 40, very high BMI. BMI is 40. And but what we found in this patient, it was done actually, it's a lived in life in terms of having 2008 and now so 17 years, and now have developed degeneration predominantly, and the little bit of mild transvalvular AR, and
AR1 is
moderate
coming.
MR, and EF was about 40%, and has an angiogram done recently with all the grafts open. So with that note, actually we are going to show you the active echo also, but let me just present a continuation. This was the echo before with the high gradient and degenerated valve, and maybe when STEM has a time can show what on the HT echo.
I will do after the cross. Is okay?
Oh, they want to cross first, but you have to show the valve or no?
No, he has recorded images.
Okay,
Stamp
okay.
show the recorded
Okay,
image.
I was trying to help you.
No, they want to.
Yes, so
These
again, mid-esophageal view.
hard.
Ejection fraction about 40%. With the posterolateral hypokinesis. Right ventricle is normal. This is a bicommissural view. It has a few chordae ruptured with moderate mitral regurgitation. This is the left lateral appendage is clean. The mitral calcific regurgitation. Minimal pulmonary regurgitation. This is the aortic valve. As you can see, the leaflets are thickened. Decrease motion. Also, the patient has aortopathy. His proximal aorta is like 4.2. This explain again, shows the leaflets, decreased excursion and thickening of the leaflets. No much AI, minimal aortic regurgitation, as you will see in the deep gastric images.
Even no.
Again, the
no,
LV function, no pericardial effusion. This is a deep gastric
3D
images. As you can see, minimal AI, no paravalvular regurgitation as you expect on this bioprosthetic valve. The maximum velocity we got today is about 3 meters per second. Mean gradient of 22, max gradient of 36. Aortic valve area of 0.5, 0.6 centimeters square. Provolume index about 20 ml per meter square. So it's a classical low flow, low gradient aortic stenosis of this bioprosthetic valve. And this is again a short axis image of the aortic valve showing the degenerated leaflets and wide open left main. Thank you very much.
Okay, so clearly it's a more degeneration versus the regurgitation, and the ejection fraction was on the lower side. We can continue our presentation of the case with the slides.
Your
so
3DRC
Get me a 3DRC.
or a no torque.
We go back to the slides, please.
Yeah,
So can we
Okay.
move
yeah, no, let me just see, go back.
Bring your T up.
Yeah,
T up.
T probe up stamp.
Yeah.
back there? You can see this is 23 magnet.
yeah.
You can see that there in the inside.
Use a guide. It'll give you more.
Not the guide, man. You just be in the center.
Your secondary ventricular dysfunction.
We can't hear you very well, Gilbert. Can you turn up Gilbert's
One
microphone?
second, okay. Fix the Gilbert's microphone, please. Now, while Gilbert, and we'll show you the active crossing the valve. Many times the surgical valves are difficult to cross. Various techniques, whether it's AR1, AL, or various wires, including V18. Sometimes we use, sometimes guide catheter helps a little bit pointing out, and that's where we are at present while we are presenting this, the rest of the presentation.
Lima guide.
I think this will be reasonable. No, I think if we can break a little bit and show what's happening with the fluoro, so that these are the tough issues, and I'm sure people will love to learn that what is your strategy to crossing this tough surgical valve.
Let's go live on fluoro.
For the time being, please go to fluoro.
So what all did you try catheter wise?
Go back to the live fluoro.
So normally LAO view, but for surgical valve, we like to go to RAO view or, go to a view where you can see a end on. So this is a different catheter. I don't think this is helping us at all.
Yeah, so AK has tried AR2, and this is IM or JR catheter,
3DRC.
3DRC. I think sometimes the guides really help in these cases gives you the support to really point in the middle of the valve. What does the panel think?
It looks like
Go with
somewhat
the
horizontal,
multipurpose guide.
Yoda. How about AL1?
Yeah.
Right. Yeah, AL1 we can use. Yeah, that's a good idea. But would you use a guide or a diagnostic?
Diagnostics should be good enough.
Okay.
Okay.
Let's get the diagnostic.
AL1 diagnostic.
Do you know, so it sounds like the gradient now is 21. What was the gradient maybe earlier on? Because it seems like the leaflets do move a little bit. I wonder if there's an element of PPM in this patient's pathophysiology.
Great question. Stam, what do you think?
I mean, I don't have the echo after the procedure, but I would say that the last echoes, there are 3 echoes that we have, and the velocities, is it's about the velocity from the transthoracic that we got yesterday is about 3.5.
Use
So,
AL1.
About 3.5, 3.6, and then remember this is about 17 years now.
yes.
The
So-
2008 was the valve, but I'm sure some part of the PPM maybe because of the 23 millimeter.
Yeah, and also
Yeah.
big aorta too, and,
And
big
the
patient.
aorta definitely is dilated also.
Yeah, and big patient. So I think it's combination, most likely of degeneration and some PPM. But the gradients definitely have increased since.
Look at the aorta.
Yeah. Yeah, I mean, I think
It's always a
surgically,
challenge.
Have a AL2 running
L1,
also?
L1.
we
No,
would
no,
expect
L1
a
going.
23 in a large patient probably would, we would leave the OR probably with something in the low teens already, so.
Yeah.
It went from the
Yeah,
you know,
I mean, but
13 to
surprisingly
21 in
patient did
18
so
years.
well
That's
until
pretty good.
now. You're right, this, knowing the area will be too small.
Get a
Exactly what
AL2
it
next.
How
So much
often are
better
you
the AL
using
catheters.
TE for this? Is that routinely used?
And remember,
this TE?
under anesthesia, they always go down by T, at least by 15, 20 millimeter. Saw it many times. I'm sure you have experienced that also. Now, right now, we have the AL1 diagnostic. With a large aorta, it's the right thing to do because based on the size. This one is the one I will start to begin with the AL1.
Yeah.
So many times we have this, our stiff Terumo wire, 038 straight tip, and difficult cases we have worked with the V18. Sometimes V18, we have not tried V18 yet, right?
No.
Yeah, no, I think that's a good point. So SS, if it's a very stenotic valve and a pinhole opening,
almost there.
V18 makes sense. But when you have huge
Still under the
sinuses
right
and a
hand.
small valve, you need directionality more than the size of the wire.
Mm-hmm.
So I think the directionality is provided by these catheters, and I think AL1 is a great choice.
Yeah, there.
Yeah,
There,
AL2
there.
would be my second option here. Very good. Yeah, keep trying. You're in the center. So you can see on echo how centered, she is, and
Give the V18 one.
yeah, go try in that area.
There.
They were asking a question, how often we do TE in these cases?
Yeah, almost all valves, we are still doing TEs. I don't know how the practice has evolved in other centers, but we are using TEs for all valves.
Yeah, you do. I mean, it's in the right sinus.
Is there a reason why you're using TE in general anesthesia so often? Why not just do surface echo and conscious sedation?
Particularly if
I
you're
think
not
that's a
doing the
very good
leaflet.
question. A lot of these valve-in-valve procedures, a lot of these valve-in-valve procedures end up requiring some kind of a fracture or end up requiring leaflet modification. So I think this has sort of been a practice. And also we want to make sure that, we have excellent gradients and there's no paravalvular leak or transvalvular leak in these cases.
Right there?
It's just been a practice. Remember, valve-in-valve is maybe 5 to 10% of your volume. So it's not that much. It just sounds a lot, but not really that much cases doing TE.
So we didn't see the CT.
Is that where it is?
Can we show the CT images, please?
We didn't hear about the VTCs and that, so.
Sure.
Just 1 second. We'll show that.
Let's
Yeah.
show the CT scan in the meantime.
Can we show the slide presentation, please, while they crossing?
Yeah.
Can people hear me now?
No, but let's, you have it.
Can people hear me?
Go direct.
Yeah, we hear you, Gilbert.
Pardon me. Yeah.
Can anyone hear me?
Yeah, we can hear you.
They can hear you now. Yeah.
Okay, good. All right, so you can see the huge root as you saw on the aortogram. You can see sinuses, and you can see also next slide that the top of the surgical valve is right at the STJ, but STJ is massive. So yeah, so you can see that there would be no coin obstruction risk, and that's why we go to fracture this and put a supra-annular valve there as well. So you can see this here
Remove your
again.
TE up, oh, okay, okay.
Remove the T. Yeah.
Access was okay, you know, a little bit
Yeah,
tortuous,
it's
but
pretty tortuous access, actually. It's, yeah, was tricky access here, guys. Very tortuous, multiple bends. So type C, transfemoral.
this is the valve-in-valve app. For those who are not familiar, I encourage you
nice.
to download that at your own
And
leisure.
record
You
this
can see that the
completely.
true ID is 21,
Hey,
so we
fluoresce.
go to
Big
fracture with a 23 true, even though they says 24. If you do 24, you might have to upsize it to a 29.
No, it just
so
prolapsed, nothing to
I
do
think
with it.
23 is still
No, that's not
probably
the
the
thing.
safest choice, because
That's
sometimes you cannot
such a
fracture
difficult
that much.
case. Because
And you can see that
what's
here,
the point? Difficult case, instead of
pocket
showing how we are
expansion.
crossing, we are talking the.
Okay, so this is the summary. So let's go back to the case.
Okay, let's go to the case with the valve fracture is the plan. Now, tell us, so you know what we saw? The very difficult, and this is where expertness, you know, usually we always bad. Anytime it takes more than 2 seconds, 2 minutes, for even a complex valve, we get all the staff extra lunch. We do lunch quite a bit. This kind of when you have the valve degeneration is in trouble, and this case, we use a V18 wire. Maybe Anu can show it.
Let me
Yeah,
tell you, okay, okay, let's show, if you can go back to fluoroscopy, right?
Yeah, you're on fluoro.
Okay, there. So like Sahil mentioned, I think it's a catheter that you needed to orient at the right spot, but what V18 does it just prolapsed. You see that? You see it prolapsing inside.
Very nice.
Yeah.
So SS loves V18, you know.
I can tell you that there is only one randomized trial of the aortic valve crossing, which 3 centers we did. There was a guy used to be Louis Cannon in Maryland, and there was one more, 3 center, 91, 92. And we came up with various strategy. And this is a V18 is a very good wire, a difficult case, particularly
Spot.
in a surgical valve degeneration.
Give a pigtail. Get us a
It's
pigtail.
not. Okay.
But
Tell
I
us
think
now
more
what you're doing.
importantly, Dr. Sharma, is the small surgical valve, right? So this is actually not that small, but the root is big. So that's the issue here. So if you have a 19 surgical valve and a big root, that's a big problem. That's very tough. Because the true ID is only 17, plus degeneration and stenosis.
One day, Dr. Sharma will tell us to use a rota wire. It's just a matter of time.
Now let's ask our audience, the panelists, will anybody do a tower? In this case, if you cannot fracture the valve.
Do we know the valve area, the perimeter of the valve area?
0.5 to 0.6, as Stan mentioned earlier.
But was that perimeter or calculated? Calculated will be
That's
low because
perimeter.
it's low flow.
It's not.
Yeah,
it's
yeah, planimeter is 0.8.
0.8, planimeter
could be,
0.8.
say, probably it's wrongly placed. Ay, ay, ay.
We are
Now,
interfering
hold
with the anterior mitral valve.
Yeah, yeah.
Now it's better now.
No, still.
I think
You were
it's just
caught, you were
the,
caught, you were caught in the aortal, the subvalvular apparatus. You can see on TEE on the long axis. So that's why we like doing TEE. You can see that, you know, I know everyone likes to be minimalist, but you know, these are difficult cases.
good, much better, yeah. So that's at the base,
Okay, now,
and we can just use a Safari now to straighten it out. Just leave it there, so.
I think
we
we
can
also
get the
should
stuff
take the opinion and the vote by our panelists. That have you started doing the tower with just minimal support, means no anesthesia, just conscious sedation and very few people in the room, minimalistic tower.
Go slow, go very slow, slower.
So for valve and valve, the only time we're
Now
using
push, push,
GA
push.
is if we're gonna
Push,
do
push,
a
beautiful.
leaf foot
Yeah.
modification with TE guidance,
Yes.
but otherwise conscious sedation. Even with valve fracture,
Okay.
conscious sedation.
Okay.
All right, TE up, please, Stan. We're gonna fracture the valve now.
Welcome, that's right.
Yep. You good?
And
Yes,
another
thank you,
point,
sir.
valve fracture before or after?
Before. Oh, yeah, let's discuss
That's
that.
that's it.
After,
Laurel, Peter, McKinney.
Before.
after.
So I think in this
Let's take the
case,
vote.
this
TE
case, I
up,
think,
please.
Yeah, more, yeah.
Yeah.
in this case, I think
Thank
you're
you.
really
Tell him to
beneficial by
show
doing it
base,
before, because there
not
looks like
this
there's
ceiling.
one leaflet fusion, and I think no matter what valve you put in, as the valve, you're gonna have trouble with full expansion, so I'd rather do this first.
No, we need to
And
view for
I know
fracture.
Gilbert discussed 23 or 24, I'd probably use a 24 true to do this.
Yeah, it's a very good point. 2 ID plus 3. Yeah, let's see how the 23 behaves. But very good point.
Yeah.
So are you guys
And everyone is
fracturing?
gonna pre-fracture, correct?
Pre-fracture.
Even Neil.
Valve is ready,
As
check.
long as you have your valve ready and you go
Okay.
fast, it'll all be good.
So this first.
I mean, there are some data to support, do it post.
Yeah.
Yeah, I mean, it does have lower gradient based on the papers, but, you know, they do have, higher mortality, this with balloon expandable valve.
That's the only.
So base
Okay,
180,
180.
please.
Okay.
And show Dr. Keeney's hand there on the. Good.
pull back.
No.
Okay, now go. Lock it, good.
Didn't they?
And Sine.
Okay,
it
broke.
Okay,
broke.
broke.
Back up, back up.
And Back up now.
100.
Excellent. Good, let's take it
So we
out.
pace at 100 to unload the LV for QAR. So when we quickly walk this out, we like to map out to make sure that your balloon doesn't, sometimes the balloon can rupture, that could be a problem. That's why we don't do inline here. We like to have an external sheath.
Pull.
Yep. Keep going, keep going, keep going. Okay, get me the evolute, please.
No.
While you're putting it, the, want to show what exactly happened there?
No, let's just finish first.
So here,
Don't do aerogram.
you can see the waist is gone on the left side of the screen.
So I think Hassan mentioned
Yeah.
about 24, right? Or someone mentioned.
Yes.
Yeah, 23 is a reasonable size here. 24, sometimes I've seen can become a little more aggressive. So I don't think it's an exact science, honestly. If you
Correct.
can get enough pressure, enough contact, you should be able to get good results.
Yep,
And some fractures, even with 24, you struggle, right?
yep.
Keep going.
So,
Would love to see the TE if the patient's stable, to see what effect you had.
Yeah,
Okay.
yeah, we'll be happy
Look
there.
at
Before you
TE now.
go in.
back here. Push the wire,
Right.
push the wire.
One view, let me find a good sun.
And give me a little jiggle.
It's not a jiggle, it's in the wrong outer.
And this
corner.
is
Sam, how does it look?
This is common when
then
the
let's see
aorta
my
is so
gosh.
big and you're trying to
some,
get this valve delivered,
Mhm.
that it's a little struggle.
There's no
So when we come here, just
No much AI that I can see.
No,
Yeah,
The leaflets though open
Yeah,
more.
it's
than
there you
before.
go.
So little
Close it,
juggle
close
always
it.
helps.
Yeah.
If
Okay.
you saw a little
So
juggle.
obviously
towards
people
the
can
end.
use snare and other techniques as well. But
Yeah,
let's
moderate-
back in now.
Moderate AI and the leaflets open definitely more than when we started.
Yep.
Bro, remove the parallax.
Yeah, I am trying.
yeah. Good.
Most likely we can now capture the jet, the center jet
That's
Grab
not
the
bad.
balloon,
actually.
balloon again.
of at least moderate AI, yeah.
Okay, 150.
Go.
Very nice.
Oh,
No.
Popped up.
The-
Okay.
I said it's very low.
no.
Go down,
Okay, good.
down,
And stay
go
there.
down. go
Stay
down.
there.
Okay,
Stay there.
go deeper.
No, deeper.
Yeah.
Okay, good. Push the wire a little
Push
bit.
the wire. And start here.
Okay, good. 180,
Give it some time.
good. No. Okay,
Okay,
100.
100.
Actually, 120.
That's nice.
Okay, still low.
Like,
Do a
push,
cine. I
push,
want to
push,
see
push,
what's.
push, push.
Yeah. Do a cine.
Push.
Good.
I would go in.
Okay, one moment.
To me, it looks okay.
Yeah,
Yeah, it looks, Cine here?
You know, the
I like
depth,
it.
Yeah.
the
What
depth
do you think,
depends
guys?
if you think you're gonna post-dilate this. If you think that there's a chance you're gonna post-dilate, because there's some space on the left side, you may want to implant this a little deeper.
But they did fracture the valve,
I
so,
think even we can post dilate with this.
yeah.
Okay.
No, two dots are below, one is.
Center the wire.
yeah, the valve tends to go a little deeper with this platform than
And Gilbert, you know from implanting these surgical valves, that what we see as the bottom of the ring is not
Base
really the bottom of the
180.
valve, correct?
That's right, yeah, we're gonna the here.
Do it under Cine. I can't see anything. Okay, thank you. Yeah, perfect.
Now
depth,
you're
guys.
better, yeah. That looks good.
Yeah, I know. Very nice.
Yep.
Push the
120,
wire, push the
120.
wire. Okay,
Okay.
and,
Pressure is a little low.
yeah,
We need to
and
push.
Back up.
good,
Back up
go to
now.
backup. And get me the balloon, please.
24.
Thank you. Go
Well,
ahead.
this is a 26, right? So IFU is only 23. This is
Give
a
me the
26
23.
envelope, no?
Uh-huh.
So, yeah.
23.
Take it out.
Help me here.
Okay.
Oh.
How does it look, Stan?
Go
No,
ahead.
no PVL.
1 second, 1 second. This is- yeah.
I think I'll go with I know this we always have. Both the Gilbert and Sahil, they always have 1 millimeter smaller balloon size than what I usually say. But
Well,
that
we're
at
good
least
to-
good thing is there's no rupture. No
Yes,
annular rupture.
that,
Yeah.
well, not that there's balloon rupture, Dr. Sharma, because of the high
Yeah.
pressure. We've seen that.
That's fine.
so- No.
Test the pacer once more, please. Yeah, just pace 110.
But Gilbert, you're choosing the post-dilatation balloon based upon the constrained portion of
IFU.
the, correct?
Yes.
And that would be
So the
23 on this valve.
P up,
Yeah.
IFU, no, I want to see the depth. You have to assume.
Depth is great. Yeah, depth is great.
Okay.
Okay, good.
Go deep on
Oh,
the
yeah,
balloon.
yeah.
Go deeper.
Yeah,
Okay,
we're
that's
good, we're good, we're good.
Okay, 180.
Cine on the inflation, please.
Very nice. Good.
Good.
Keep pacing, keep pacing. Keep pacing, keep pacing. Keep pacing, 150.
Careful, careful, careful. Wait.
Yeah. And
Okay, back up, up.
That was an
Okay, got a
excellent,
pigtail.
Okay, good.
that was an excellent result. You moved that valve even further out to the surgical valve.
Yeah.
yes. And I think you appreciate the depth, right?
Mhm.
It can be misleading sometimes, but
So the dot marker is helpful,
this
so
is short
to be
action.
fair,
Nothing.
the
Take it,
left
take it,
side of
take
the
it.
screen is around 1, okay? So the other side is around 2 and 3. So if you really want the supraannular benefit, and I think so, this is about as high as you can go. The problem is that we capture once already, you can't become rubbery and you kind of perfect the enemy are good. I don't disagree. I think for the less experienced implanters, going a little bit deeper to what I popped out is very reasonable. You don't want to be 6 millimeter deep, then you kind of lose the advantage of the supraannular benefit of the Evolut platform. But you can see here that, you know, if you experience and you coordinate your deployment with your operator partners, then this kind of result is certainly feasible. And the other reason for that is that if you do plan to fracture post, you cannot implant at this step.
yes.
No way, because then the valve will come up when the fracture happens and you end up foreshortening more. So if you do that, you commit to a deeper implant. And then if you try to post-fracture and it does not fracture, then you lose all the hemodynamic benefit and the reason to do that. So that's why we like to pre-fracture, and we
Zero.
haven't lost a patient hemodynamically because of that.
And do you want to talk about your commissure alignment of the evolute valve versus the surgical valve, what you were thinking about with implantation?
Yeah,
So-
great point, Steve. We have to show you in fluoroscopy what it looks like in terms of the surgical post. So we can go on maybe a.
200
crossover
scale.
view.
200 scale.
200.
Done.
So that's a perfect hemodynamic result. Can we show the hemodynamics, please?
Showing it, yeah. Good. No gradient.
By echo 7 and 3.
It's actually 3 also there.
Looks beautiful.
The MR also got better.
Yeah.
Yes.
Excellent.
It's beautiful, guys.
I told these people, right? 100.
Yeah, a little challenging, huh, with the capacious sinuses and
This is the
All
amount.
right, so here is so we do the crossover. You can see the commercial tab on the right side of the screen lines up with the surgical post on the right side.
It's
So that
perfect.
means we have excellent commercial alignment. In fact, you can see the two windows very nicely overlaying each other. So this is in essence excellent commercial alignment to near perfect.
Yep. Great.
we
And
have a break now?
No.
we
Good.
can-
no,
Mr. Hill,
no,
Mr. Hill, do you want,
But let's talk about few things.
yeah,
One, who will give both aspirin and clopidogrel to this patient, or anybody will
And
give?
anticoagulation.
Yeah, anticoagulation.
Tell them full screen,
Excuse me.
Put 3D.
full screen.
What's the opinion?
Well, the trial suggests single antiplatelet is all you need. It reduces bleeding.
and then, one technical question I wanted to ask you, Sahil, is when you were trying to get the valve, the evolute valve inside the surgical valve,
This
if you were
camera.
still stuck, what other tricks would you use to get that valve inside there?
Oh, yeah, that's a great question. So if you see, my nose cone was very close to the top of the stent frame. If you keep pushing there, it's just gonna keep engaging and bend into the stent frame. So what I did was I gently pulled it up, rotated the system, and Dr. Kinney was jiggling the wire. When she pulled the wire slightly, I got space and I pushed it in.
Is there a wire that makes a difference? Have you had to ever resort to unveiling part of the valve to get across? What other things can you do?
So, yeah, so.
I think it's a
people-
combination of both.
Yeah,
Wire and advancing the valve at the same time. So if you see the valve was at the outer curve, so we had to pull it back, reorient a little bit, and then it's both the wire, you pull the wire back, at the same time advance the tower.
Should we do an aortogram or no?
Yeah, do it.
people have used snares in the abdominal aorta. The Lundequist wire doesn't help, it biases more on the greater curve. So snare can be used, otherwise just jiggle.
Haven't we changed the wire, double wire?
We've tried balloons, we've tried double wires. We've struggled a lot sometimes.
Okay, we are going to show the aortogram and then we'll be done and exactly at 12:10 for your lectures. What a perfect timing. Wow.
Perfect
Gilbert
timing.
and
Perfect
AK
timing.
and Sahil doing a great job. Not even a 1 minute late or early.
You have time for another case.
Symposium.
Yeah.
Can I take the pro?
We actually have
I think we're okay.
a case, minimalistic case in our coronary room.
Not yet. Okay, just do it.
Okay, ready?
Yeah,
Yeah.
Yeah,
Go.
just the hair, but they did, this is good.
we may be behind.
Beautiful result.
Wow,
Yes.
not even a single RBC. All right.
Okay, you
Let's go,
guys,
guys.
thank you. You can proceed the lectures.